Barbara, could you just say a little bit more about the role of the local municipal level authority? It's not something we're that familiar with in terms of being involved in commissioning in healthcare.
The local authorities currently have a responsibility for what is known as creating a sense of place for their local communities. So all of the services that are delivered locally, the local authority will have a role in, either by delivering them directly themselves or commissioning them directly themselves or acting as an integrator for other services. Now, they've done a modest amount of that on healthcare in the past. They're now getting a much more specific role as the integrator and being tasked with delivering against a set of outcomes. So whereas in the past they would contract for social care, they would provide local infrastructure like roads, they would be responsible for the environment locally, they would have a role in education and in policing and in fire services and all of the kind of municipal services. They will now also have this very clear responsibility for integrating across health, social care, and a new responsibility which they will exercise direct in that they will employ the directors of public health. They will have a ring-fenced public health budget, which currently sits in the health service, will now sit in local authorities. And their aim will be to make sure that that prevention, health promotion, public health function is also part of the integrative process that they use. The local authorities are all sort of sitting back on their heels at the moment because it's a bit like your dad coming home and saying he's bought you a fish and you discover it's Moby Dick, you know. There has been a huge push by the Conservative local authorities to endorse this belief that local is best and therefore the local authority is best placed to assemble the best package of public support around its population. But having looked at what that actually means, they're all going, sometimes you wish you didn't get what you wished for. So it will remain to be seen how effective they are. There will be some local authorities who are already in that game. If you look at places like Birmingham and Liverpool, they are pretty effective in doing that integrative task. If you go to Nether Wapping in the marshes, where they can barely get the fire service to turn out, it's going to be a difficult issue.
Thank you. Michael.
Yes, one of the many details that these integrated systems can flounder on, of course, is the essential, what is the cost per patient? What is the capitation payment? Or as our American friends would say, how much per covered life? As somebody who's been very fond of thinking about these, because it's like four-dimensional chess, right, to think about how to make sure everything's done right, and having, you know, written something about my favorite integrated model, that is one of the key issues. And I'm particularly thinking, I know you've been more sophisticated in Britain in looking at different ways of trying to actuarially and epidemiologically fairly calculate what people are worth. But for example, in Ontario, where we've now got 25% of family doctors being paid on capitation with a program that hopefully will change in a few years, but appears to it paying them average rates for patients that are almost certainly, we know, not a lot healthier than average. So there could be like $100 million or more actually being misallocated right now, and it's going to be a lot more in the future. So that's just one example. How are you going to do this? How are you going to deal with the cream skimming issue? And I'm ready to move to your place and make a lot of money. It sounds like there's some big opportunities. Thank you.
To compound it, to compound all of that, there is going to be a kind of split system for operating the tariff, which is what providers are paid. The National Health Service Commissioning Board will structure the tariff, but the actual levels of payment will be set by Monitor, the economic regulator. So that's going to be pretty complicated on the tariffing side, i.e. what can providers charge. And on the commissioning side, we will continue to allocate in the same way as we currently do. We allocate out to PCTs, we'll be allocating out to GP consortia. The risk will be that if there are more of them and they're smaller, the ability to get it wrong at the margins is greater. So they're going to be required to enter into a risk pooling process. A risk pooling process partly on the basis of, have we got the population number wrong and does it start to grow? And partly on the basis of, have we got the severity of the case mix and the severity of the dependency of their population wrong. And the detail of the risk-sharing agreements have not yet been worked through. Even more heroically, there is going to be a continuation of the current attempts to build incentives into that process. So, in fact, we don't often operate on averages. We often operate on where we want payment to be. So, as an incentive through the tariffing system, if there's something going on that doesn't look as if it's best practice, it will be paid below tariff. And there will be an incentive by paying a more generous tariff for patterns of care that we want to happen. So by playing tunes on the tariff, you can begin to get a smarter commissioner and a smarter provider working out how to move practice. The big job, of course, within the providers themselves will be how do they get clinicians to engage with that process and to deliver the patterns of care that are required. So it's a complex system.
John.
We had Jim Easton here earlier this year, and he gave what I thought was a pretty compelling talk, and I see lots of people in this audience who heard him speak. And he, of course, is charged with, at least he was then, maybe he isn't now, but with taking the 20 billion pounds out and improving quality at the same time. And he made it pretty clear that the strategic health authorities were his key lever in holding them to account for helping to achieve both the quality targets and the savings. And I guess my question is, what now?
Well, I think that depends on which of the kind of scenarios that I painted at the end comes to pass. Mm-hmm. I mean, you could say that the NHS Commissioning Board is actually just going to be a kind of next stage of development for NHS top-down management, and that the regional manifestations of that, and I'm sure it will have to have regional manifestations, mm-hmm. will be a substitute for the Strategic Health Authority, so the levers will still be there, but they'll be exercised through the commissioning process rather than through the management process. Or you could say that this is a much more radical market-based approach, and that therefore the way in which Jim is going to have to think his program through is going to have to change markedly, and it's going to have to very much focus on things like the outcomes framework and the way the regulator behaves and all the other levers that you've got on both providers and commissioners that set the framework in which they operate. I suspect it's going to be a mixture of the two, a rather unhappy mixture of the two. But knowing Jim, he'll have knitted one somewhere and will produce something he's prepared previously.
Well, good luck to him and to you.
It's amazing what you can do with toilet roll thingies and sticky back plastic if you put your mind to it.
Thank you very much. There are a lot of UK watchers in this audience. We have a habit of it. We sometimes get exhausted simply watching. This time around, $20 billion, major system change. My question is, how does your system cope with this massive change on all fronts? And I guess the pointed question is, will the system engage with this kind of massive change? What is it about the culture of your system that will allow this?
I'll tell you a little anecdote. I think I still have the record for closing more hospitals than any other human being in the National Health Service. And I was doing a night visit to one of my hospitals where a little nursing auxiliary came up to me and she clasped me by the arm and said, "Are you Barbara Young?" And I said, "Yeah." And she said, "I just want to say one thing to you." She said, "When I was working at Princess Louise, you shut it. And when I was working at St. Charles's, that I moved to, you shut it. And when I was working at St. Columba's, that I moved to after that, you shut it. She says, would you tell me where you're going to shut next? She said, because I'm not going to go there. And I felt terribly ashamed, you know, because that was real kind of human suffering. And then she said something that set me back on my heels completely. And she said, it's not that I don't like change. We know how to do change, she said. And I think that's the thing. The NHS has been kicked around so much in these big system changes for the last 60 years that it knows how to do change. But the big problem is, while it's doing change, it's not making some of the progress that that energy could go into in simply tackling the issues rather than the structures. That's my great grievance about the National Health Service, which is why I bailed out before the election and went to the voluntary sector, because the idea of doing another one of them was more than I could stand. But at best, I think the NHS will buckle down and make these changes. They will probably be a lot slower than Langsley thinks they are. He'll find himself facing a general election with one foot in one system and one foot in another, and that may be a very uncomfortable thing facing an election. The wheels won't fall off because committed professionals won't let them. The standard of service will get poorer for a while until the new system really kicks in and sees whether it can develop the potential. And we'll have expended a lot of money and a lot of effort and energy on facing in a direction that I think we're already facing in, rather than simply using the levers that existed to get the outcomes that we wanted. So that's what will happen, I think. But it is cyclical. There's a lovely diagram, actually, that shows the NHS over the last 60 years, because between 1948 and 1974, absolutely be-all happened by way of restructuring. And then 74 to 82, and then 82 to 85, and then 85 to 88. And on current performance, that means there's going to be a reform every 13 minutes.
Well, thank you, Barbara. Did you want one more question? Okay. Two more questions? Two more short questions? Sure. Go ahead.
I find it kind of interesting that at the same time you're going for probably more change than you've had in all those various reorganizations, you're cutting back on some of your ability to change. You know, it's fine to say we're changing the purchaser-provider split, but you have to have providers to purchase from. And as you move to foundation trusts, it's going to be harder and harder and harder to change that mix of providers, particularly on the institutional side, because you can't build a hospital overnight or change the game overnight. How do they intend to deal with those kinds of constraints?
I think a real purchaser-provider relationship, a really effective one, is much more of a partnership than a contracting relationship. And the reality will need to be that if there are going to be big reconfigurations in the interests of improved effectiveness and efficiency and quality, that will need to be driven by consortia ganging together with the providers and coming up with a deal about what the reconfiguration is going to look like. London is a prime example of it. London had actually got itself to a position where all of the PCTs, working with the Strategic Health Authority, had come to a view about what the configuration of London's hospitals should be. And Mr. Langsley, bless his heart, cancelled the whole thing as he came into power. And it will be a long time before the new arrangements have got that sufficient degree of trust of each other to really do that revamp, I think, which is unfortunate. But it shouldn't be impossible, but it will be more difficult, particularly if you've got a provider who's going to hang on by their bootstraps regardless. We've got one or two hospitals in London that have been up for closure so often that you know, they know how to fight it off now. Usually involves phoning minor royalty somewhere along the line. But you know, if we're all mature about it, the line I'm taking is, this is the show in town. It's going to be in town for 10 years because we're not going to see a Labour government returned at the next election. And therefore we better get on with trying to make it work get through the pain of the restructure as quickly as possible and get on with trying to make the new system work.